Gonioscopy assisted transluminal trabeculotomy, passing the right way, decoding the suture. Cataract and glaucoma are the most common cause of blindness around the world. The most widely performed IOP lowering procedure worldwide is trabeculectomy and combined with trabeculectomy with phacoemulsification. But this procedure has considerable numerous vision-threatening complications and BREB-related complications. Minimal invasive glaucoma surgeries are ab interno conjunctiva sparing procedures with moderate intraocular pressure lowering effects and good safety profile. GATT is a type of MIGS procedure in which we cannulate the Schelm's canal by passing a proline suture. Indications being primary open-angle glaucoma, mild to moderate stages with or without cataract, secondary open-angle glaucoma, all stages with or without cataract. Instruments we need for surgery: panel salt solution, 25 gauge MVR blade, 30 gauge cannula, 15 degree blade, Hilongi viscot, Swan-Jacob gonio lens, micro-tying forceps, low temperature cautery, 50 proline suture. Patient bed manipulation and microscope tilt. The microscope has to be tilted towards ourselves and the patient head on the opposite side. Now, after applying adequate amount of OVD, we place our Swan-Jacob gonio lens and visualize the angle. Second step being preparing the suture for the goniotomy procedure. Here we use a low temperature cautery to prepare the tip of the suture. The tip should neither be too big nor too small. Under direct visualization of the gonioscopy lens, we do 1 to 2 mm goniotomy at nasal angle. Then the microsurgical forceps is used to guide the tip of suture through the goniotomy cleft into Schelm's canal, and then the tip is advanced around 360 degree. Minimum 20 to 25 strokes are needed for a complete pass. After the suture has coursed the entire canal, the tip appears on the opposite side of goniotomy cleft. Leading tips is grasped with the microforceps. The external trailing end of suture is grasped near the cancel size. General traction is applied to externalize the leading end, creating a constricting loop that gradually cleaves the entire trabecular meshwork, completing the 360 degree ab interno trabeculotomy. Then last step being anterior chamber wash. If any residual blood is there and the visco is removed and the wounds are hydrated. 41-year-old male presented to us with left eye having secondary open angle glaucoma with uncontrolled intraocular pressure even with maximal medical therapy. Anterior segment examination showed silicon oil bubble in anterior chamber, which was also evident in gonioscopic examination. First of all, we remove this all silicon oil from the anterior chamber, measuring the circumference of the suture required, kinking it, preparing our tip of the suture. (1 to 2 mm goniotomy). Passing the suture. Retrieving it leading trip grasped, and 360 trabeculotomy being done. Frequently encountered intraoperative problems and solution. How to pass suture. Pass the suture first through inferior nasal angle by using microforceps. Around 20 to 25 strokes needed. First 90 degree are the site of maximum resistance. What if suture stops? Gently pull back using microforceps, create new goniotomy. Pass the suture in opposite direction through new goniotomy to treat remaining angle. Intraoperative bleed. It is usually minimal and not a complication. Use visco to push away blood to improve visibility. Fill 25% of anterior chamber with viscoelastic in end of surgery. This will prevent further bleeding and decrease likelihood of postoperative hyphema or clot settling over the pupil. Prolene suture tip should be neither too big nor too small. If suture end is tapered, cut it and make the suture tip with low voltage cautery. Measure the total circumference with prolene suture and kink suture to estimate how much length of suture required. While making corneal incision, avoid blood vessels. Proper patient head position and microscope tilt to visualize angle anatomy in high magnification. Avoid air bubble in between lens and cornea. Keep anterior chamber formed at all time using cohesive viscoelastic to avoid distorting the angle view and to create a space to move your surgical instruments. Little visco can be used at goniotomy site to enlarge it. Start with inferior nasal angle. Look for iris bulge, which indicates suture coming out of canal. It is normal to have some resistance at 180 degree. To conclude, with minimal risk of postoperative hyphema, we have added benefits of conjunctiva sclera sparing procedure, good IOP control, less invasive, and filtering surgery and GTT plantation can be performed if GATT fails. Thank you.